Good afternoon, everybody. My name is Jamie Bloom, and I am going to be doing part B on our condition presentation of bulimia nervosa. I am going to apologize in advance because you may hear children either yelling in the background. They may either be mine, or it's actually a very nice day today, so there's a bunch of kids playing outside. The article that Sabrina and I chose for our presentation came from the Journal of Psychiatric and Mental Health Nursing. It was titled Anxiety and Compulsion Patterns in the Maintenance of Binging, Purging Behaviors by Individuals with Bulimia Nervosa. And that is by Thomas and Lovell. This paper reports on the results of a study into the self-reported coping strategies by a small sample of individuals that were diagnosed with bulimia nervosa, purging subtype, and severe and enduring eating disorder, which is also known as CBN. They were referred to an outpatient clinic for psychotherapy. Data collection focused on the vomiting activities of participants through analysis of their self-management from diary extracts, which recorded their vomiting patterns. The participants all experienced significant mental health issues. They had complex histories of bulimia nervosa over a prolonged period, difficulties maintaining relationships, and many had an additional history of substance misuse, which included dependence on prescription drugs. They found that two different self-management strategies, which was anxiety containment and compulsion maintenance, were pretty prominent. So just a little backstory. I know that Sabrina just talked about this, but bulimia nervosa is a high-profile eating disorder. It's characterized by powerful and intractable urges to overeat. Typically because weight gain is usually the consequence of overeating, it's sorted by vomiting, purging, or periodic starvation. It affects around 3% of the population worldwide, and it's the most common eating disorder, and it mainly affects women, but men are affected as well. It is usually emerges in late adolescence or early childhood. It may persist over time and is frequently associated with anxiety and depression. If it's unsuccessfully treated, then it becomes severe and enduring eating disorder, bulimia nervosa, which is CBN, and that's frequently associated with anxiety and depression. Purging behaviors, particularly self-induced vomiting, have received increased attention over the recent years, and both in the context of eating disorder. Self-induced vomiting was initially regarded as an undetected problem because of the high level of secrecy, but an early influential study suggested that more than half of those diagnosed with BN, or bulimia nervosa, vomited daily, and 17.5% actually vomited weekly. There's 3 criteria, which is usually essential: recurrent episodes of binge eating, recurrent inappropriate compensatory behaviors to prevent weight gain. Could be excessive exercise, use of diuretics or laxatives, and self-evaluation that is shaped by body shape and weight. The condition that is considered severe when the behaviors occur 8 to 13 times each week. It's also considered extreme when the behaviors occur 14 times or more each week. According to Thomas and Lovell, there's a marked association between bulimia nervosa and diagnoses of other conditions, particularly mood disorders, substance misuse, borderline personality disorder, and obsessive compulsive disorder. Purging behaviors are clearly elevated when borderline personality disorder, depression, or anxiety disorders are also present. Compulsive urges also appear to alter as the condition develops, with vomiting characterized by an acute lack of control in the early phase, evolving into impaired control as the condition becomes enduring. Obsessive thoughts are an invariable product of the individual with bulimia nervosa constantly thinking about food, weight, diet, and body image, and that these thoughts are often intrusive and negative, leading to distress and frustration. Excessive self-differential thinking reinforces that anxiety and low mood states, which, when paired with uncontrollable urges related to negative beliefs, are important in the maintenance of bulimia nervosa and reinforce negative thinking around change and control. Compulsions can be severe, intense. They can reinforce feelings of anxiety, and they're extremely difficult to overcome, despite the damage to the individual's overall health. Attempts to suppress or ignore obsessive thoughts and perceived loss of control over intrusive thoughts actually led to an increase in thought frequency, loss of concentration, and increased anxiety, generalized enough to kind of take over their functioning. Compulsion may serve to allay feelings of anxiety, but maybe only temporarily. And impulsivity, in the context of bulimia nervosa, might serve to block unwanted emotions. An early study on bulimia nervosa proposed that increased purging behaviors were correlated with increased psychological disturbances and decreased compulsive control, and may constitute a subtype, which could be multi-impulsive bulimia. 80% of people experiencing bulimia nervosa engage in purging behaviors, and 16% include vomiting alone. The others, like I said, laxatives, excessive exercise, and things of that nature. Cognitive behavioral therapy, according to Thomas and Lovell, is found to be more effective than supportive psychotherapy in reducing the frequency of binge eating and vomiting. Experience of depression and anxiety appears significant in the backgrounds of those with partial bulimia, with the use of alcohol and chaotic family background, which is pretty prominent in those with full bulimia nervosa. 3 research questions were formulated for this study. The first is, how influential are vomiting events in the lives of individuals with SEED bulimia nervosa, which is, severe? What coping strategies do people with this condition employ to sustain vomiting behaviors, and how can nursing, assessment, and treatment be most effectively addressed for people with CBN? The study used a qualitative approach, and it evaluated self-reporting coping strategies and self-interventions through diary recordings of binging and vomiting. Because vomiting is not usually a public act, observations are kind of impracticable, and their self-monitoring can be effective in promoting behavior change. So they just wanted to make sure, those that suffer from bulimia often don't vomit in public. It's something that's held private. So kind of diary reading was one of the only ways to actually get, an accurate information. The participants comprised of 11 women and 1 man. They were between 23 and 46 years of age, and they pretty much had they were presenting with a history of CBN of between 5 and 26 years, and the average was about 12 and a half years. All were within normal or just above normal weight. Using the body mass scale, the BMI average was 24.7. All participants scored significantly on depression scales. 9 reported histories of prescribed antidepressant medication. 3 had alcohol dependence, and 2 others used cocaine at least weekly. 7 participants recorded marked anxiety levels prior to their bulimia diagnosis, and all had chronic physical complaints. They all had history of self-injury, which included cutting, scalding, and burning. 8 had histories of suicide attempts, and 5 had received inpatient psychiatric admissions. 9 had histories of abuse in their families, familial abuse. 5 were of a sexual nature, and 4 were physical. 9 of the people had difficulties in maintaining relationships, but 3 of them were in long-standing relationships. Diary recordings were analyzed to discover if there were any themes related to self-management of resisting binging, the frequency of vomiting, and any dominant clinical presentations. The review focused on the coping strategies of these 12 people. They were referred to as severe and enduring eating disorder outpatient clinic for psychotherapy over a period of 2 years. And they had met the DSM-4 criteria for bulimia nervosa purging subtypes. Severe and enduring bulimia nervosa was defined as an eating disorder with more than 5 years of constant bulimia symptoms without remission and at least 3 previous psychotherapeutic interventions. All participants were provided with information before giving consent. Approval was given through the University Faculty Research Ethics Committee, and the participants were ensured anonymity and confidentiality. Findings of the data indicated that there were 2 distinct coping patterns to be present. One was anxiety containment, which was basically those with more control over their daily vomiting episodes, and compulsion maintenance, which were those who were overcome by the urge to vomit once or more daily. Anxiety containment involved the individual consciously trying to control the vomiting pattern. They kind of basically adopted a risk management approach, which basically took steps to avoid being caught, to ensure that they were alone, checking that their partners or their children were out or asleep, organizing a sufficient enough time to binge, to vomit, to clean, and to shower. They also had to kind of pre-plan, which included hiding money for food, pre-planning shopping time, and choosing appropriate clothing, which was usually loose-fitting, easily washable, normally dark-colored, to hide stains. This pattern was assimilated into their daily lives. The planning process provoked anxiety and fear of the unexpected. Vomiting episodes were planned and led to an immediate reduction in tension, although guilt and depression were reinforced. The build-up to an episode of binging and vomiting entailed the battle with contradictory emotions such as self-disgust and underlying anger, which basically increased hyper-awareness and tension throughout the day. Negative thoughts were reported around self-worth and confidence, with vomiting used as a means to reduce anxiety, anger, guilt, and a low mood. The participants that were engaging in daily vomiting reported anxiety but more compulsive traits. Their resolution to resist vomiting lasted maybe no more than a few hours before the physical discomfort became overwhelming. More deceit and concealment was involved than with the anxiety containment group. Intrusive thoughts about food, eating, and body image were also almost constant. The compulsion to act became extremely difficult to resist. Vomiting was more opportunistic, involved more risk-taking, such as eating more openly, with friends, and continuing once others had finished. Vomiting was usually self-induced in a public restroom, in the toilet. Participants reported binging at home when others were out and during the night, with associated risk-taking revolving around replacing the food, concealing food, and also sometimes concealing money. The participants also discussed past therapeutic interventions, which confirmed their perception that compulsive urges were too strong for any attempt at self-management. Past therapy appeared to have increased the severity of the symptoms. and they all experienced and resented the intrusive obsessive thoughts and compulsive behaviors that burn in their daily lives. The compulsive pattern of vomiting appeared to be associated with more confused thought and contradictory thought patterns, fear of the consequences of the binge vomit cycle, a distorted self-image, insight to their own behavior motivations, which pretty much all conspired to propel them onward in the self-destructive cycle. According to Thomas and Lovell, the severity and enduring nature of CBN exacerbated over time, participants becoming increasingly helpless to resist thoughts about weight and food, and the short-lived relief from vomiting being undermined by self-disgust and shame. Compulsive daily vomiting involved an element of negative learning, poor control over vomiting urges, despite previous therapy experience, which paradoxically resulted in decreased discomfort. Vomiting helped deal with unwanted symptoms and a belief that actually, ameliorated these feelings of escalating physical and affective distress. It seems reasonable to assume that individuals that were presented with anxiety containment, bulimia nervosa, differ in their bulimic experience and behaviors from individuals presenting with compulsion maintenance. Deferred gratification was found in the study to be utilized as a control mechanism until stress was deemed to have reached a level requiring tension release, which was usually short-lived. Participants with compulsive maintenance, bulimia nervosa, had higher levels of compulsive traits and depression, while anxiety containment, bulimia nervosa, appeared to indicate more anxiety, less of obsessive compulsive traits, and higher anxiety depression. Participants with anxiety containment may be better supported if they work within a group. In addition to individual therapy, the individual therapy focuses on anxiety management using cognitive behavioral approaches. Participants with compulsive maintenance strategies may respond to individual sessions, which focuses on reinforcing abstinence strategies, and maybe group work can be allotted to the management of addictive behaviors. Some more information on bulimia nervosa can be found on these websites. The National Eating Disorders Association is the leading nonprofit in the U.S. advocating on behalf of and supporting individuals and families that are affected by eating disorders. Bulimia.com is a great resource that's dedicated to providing information and treatment options to men and women who are suffering from eating disorders. The Academy for Eating Disorders is global access to knowledge, research, and gives some best treatment practices for eating disorders. Then there is the National Institute of Mental Health, which is also a great resource, and Eating Disorder Hope, which offers educational support and inspiration to eating disorder sufferers, their loved ones, and also eating disorder treatment providers. So I hope you enjoyed our presentation, and I hope you all have a very nice afternoon.